So like I said, the medical management of HHS is very similar to DKA. Only thing to keep in mind is make sure that you're starting insulin only after you have adequately resuscitated with fluids. So that, there's no hypotension. And you need to be careful if there's a history of heart failure when you're giving fluids. You have to be careful so that you don't push the patient into pulmonary edema or further heart failure. And like I mentioned, the potassium replacement is one thing to keep in mind. And another thing is, don't do a very rapid reduction of sugars, because that can result in cerebral edema. So you have to bring it down gradually. It is not something to be that you have to immediately bring it down from 600 sugars to 100 or 150. It has to be done in a gradual manner, which is why the protocols are very important. So because DK and HHS can result in complications, like it can cause cerebral edema, like I said. So if you try to reduce the blood sugars very fast, then this can happen. So your sugar should ideally reduce at the rate of 50 to 75 mg per deciliter per hour. That would be ideal. So other complications of DK and HHS are hypokalemia, hypoglycemia, acute pulmonary edema, hypophosphatemia. All of these things need to be looked for, and they have to be treated as well. So going ahead, there's another case scenario that I would like to discuss. So 25-year-old Geeta, who's having type 1 diabetes, is on insulin. So she's come again to the emergency with a similar disorientation, and she's not responding since 1 hour. And there is no chance for you to check blood sugar. So what would you do out of these four options? You can just put in your answers in the chat box. Would you give them insulin? You don't know that you can't check sugars, so what would you do? Would you give insulin, or would you give dextrose, or would you check the urine sugar, or shift the patient to a higher center? Okay, somebody says check the urine sugars. Another person says give 25 ml or 50% dextrose. Okay, C. Any other answers? Only 3 people. Okay, B. All right. So this is most probably a hypoglycemia, because the patient is a type 1 diabetes patient. She's on insulin. So it's possible that she might have taken her dose and, not eaten her food properly. So she might be having a low sugar. So she's disoriented. She's not responding very well. So if there is no way to check the sugar, then it would be prudent to give her the dextrose, assuming that it could be hypoglycemia. Um, okay. So, this is the third emergency, diabetic emergency that can happen. One second. Yeah. Just So, hypoglycemia is caused by either too much of medication, so normally over medication, if they're not eating enough amount of food, and if there's too much of a physical activity. Normally, these are the three things that bring a patient to hypoglycemia. So, normally there's an increase in epinephrine and norepinephrine that results in the symptoms like sweating, tremors, tachycardia, palpitations, hunger, nervousness. All of these can happen. It can also start affecting the CNS, resulting in lightheadedness, confusion, not able to concentrate, memory issues, slurred speech. So all of these can happen when the sugar goes down. So basically, when the supply of sugar or oxygen to the brain reduces, that's when all of these things can happen. So normally, what do you do? How do we treat a hypoglycemia? So if the patient's GR, so first is, suppose if you have a facility to check the sugars of the patient, then you do a GRBS immediately. If the patient's GRBS is less than 60 mg per DL, if the patient is conscious, then you don't have to give IV fluids. You can just give her 30 grams of oral glucose, and then you can follow it up with some complex carbohydrate like a cup of fruit juice or a slice of bread or a glass of milk or something like that. Suppose if the patient is not able to eat, the patient is unconscious or semi-conscious, the patient comes to you, he or she is unresponsive, then you can give an IV bolus of 20 ml or 50% dextrose, and then you can start a IV fluid at 5 to 10%. 5 to 10% dextrose IV fluid, you can start at 100 ml per hour till the patient becomes stable. If at all you have the facility and if required, instead of giving dextrose, you can also give injection glucagon 1 mg stat. So this also is something that is used. You can check the sugars again after 15 minutes, and you have to keep rechecking the sugars and do this again till the GR base increases to more than 100. And then you can, once the patient is stabilized, once the sugars have come up again, then you can slowly evaluate the cause and then you can address it as well. Okay, so there can be various causes. So sometimes some medications, or there could be some other underlying causes, infection. So all of that also can result in hypoglycemia. All right. So, going ahead to the complications of other complications of diabetes. So, normally what happens? Okay. So, a patient who is diagnosed, initially it starts off as a glucose intolerance, as an impaired glucose tolerance because of various reasons like genetic susceptibility. It could be environmental factors like nutrition, obesity, not doing enough exercise, all of that, which can result in insulin resistance. And slowly over a period of time, a patient starts becoming intolerant to glucose. It can also have other effects like increase in triglycerides, increased blood pressure, reduced good cholesterol. All of these things can also happen. So then when the patient gets diagnosed with diabetes, if the patient's sugars are not very well controlled, if the patient continues to have a high sugar levels, then slowly there can be complications which arise, which result in disability and then resulting later in death. So this is the cycle that a diabetic patient usually undergoes. So, like I said, chronic complications, you can have macrovascular, microvascular. So, macrovascular complications like cerebrovascular disease is one of the leading causes of diabetes related deaths, and it is very common among type 2 diabetic patients. So, that's why it's very important for us to screen patients for cardiovascular disease when they have a underlying diabetes or even hypertension for that matter. Microvascular complications like retinopathy, nephropathy, neuropathy, these are all common. Again, nephropathy is accounts for 44% of all the end-stage renal disease cases. So you can imagine the load of diabetes and its complications that it can have on a person's organs. Neuropathy also, almost 60 to 70% of diabetic patients will have some sort of a nervous system damage, at least a mild neuropathy they will have. So that's why it's important to have a good sugar control. So cardiovascular disease, like I said, chance of MI is 4 times more in those who have diabetes than those who do not have diabetes. Why this happens is because dyslipidemia is common in diabetes. Okay, because of insulin resistance. So this results, like I said, in raised triglycerides, reduced good cholesterol and all that. Also, there'll be endothelial dysfunction, which increases the pace of atherosclerosis. Than somebody who's non-diabetic, somebody who's diabetic, their atherosclerosis moves very fast. So the plaques will build up much faster in a diabetic person. Also, it can affect the microvasculature, even in the heart as well. So that is another thing. It can cause autonomic nervous system gets affected. So diabetic autonomic neuropathy can affect the heart as well. So this sort of reduces the blood flow to the heart. This results in a higher chance of sudden cardiac deaths and all of that. So these are some of the reasons why. Also, there's increased oxidative stress. There is hypercoagulability. There are activated leukocytes. So all of these things can result in cardiovascular disease. These are the reasons for cardiovascular disease in the non-diabetic as well. But these are much more faster and more, aggressive when a patient is diabetic. So, like I said, insulin resistance can result in CVD in diabetic patients. So, there are various risk factors. I think we all know this. So, there are modifiable, non modifiable lifestyle, as well as the social risk factors for CVD. So, under modifiable, the sugar or the blood sugar or the diabetes comes. Of course, there are other things as well. So how do we manage? So one thing that you need to do is any patient who is diabetic, if the patient is coming to you, annual screening for certain diseases becomes very important. Like, doing an ECG once a year, checking their sugars, checking their HbA1c, do their lipids once a year. Also, always remember to look at their fundus to look for retinopathy, as well as do a test for peripheral neuropathy. So all of these things have to be done at least once a year for all diabetic patients. And remember the three ABCs in diabetes. So A is the A1C target. So make sure that the HbA1c is less than 7%. Uh, in an elderly patient, you can keep a target of 7.5. As they get older, even around 7.5 to 8% is fine. But lesser than 60 years, I think less than 7% would be an ideal HbA1c target. The second thing is making sure that their blood pressure is less than 130 by 80. Third thing is cholesterol. So managing the cholesterol level. So primary prevention, you can start the patient on cholesterol, if at all. Again, that is also based on criteria. So there is something called as an ASCVD risk scoring. You can get it on Google as well. So you just need to enter a few parameters and it will give you the risk score. So if the patient's risk score is between normally if it's less than 5%, then it's a low risk. 5 to 7%, 7.5% is intermediate risk, and more than 7.5% is a high risk. So if the patient has more than 7.5%, then you need to start the patient on statin therapy with an LDL goal of less than 70 milligram per deciliter. Suppose if the ACVT is less than 7.5, then you can advise lifestyle modifications, ask them to stop smoking, ask them to have a balanced diet, start exercising. All of these things need to be advised. So, this is about cardiovascular disease. So, the next thing is diabetic nephropathy. So, going to the microvascular complications, the diabetic nephropathy is also very common. So, it is the leading cause of end-stage renal disease in many countries, and it can happen in both type 1 and type 2. More likely in type 1 because it's there for a longer duration basically. So that is why. And normally it happens in patients who have a poor glycemic control. If they also have elevated blood pressure and lipids, then they're more likely to develop nephropathy. So also the other thing is because diabetes can also cause hypertension in the renal vessels. This can resulting in narrowing of the glomerulus and all that. So this results in the narrow vessels. There are deposits that happen. There is scarring that happens. There's a vascular damage that happens. So there can be oxidative stress. Basically, when the sugars are uncontrolled, right? So there can be inflammation, hypertension. So all of these things can result in diabetic nephropathy, resulting in loss of proteins in the urine, which is albuminuria and glomerulopathy. As slowly over a period of time, there's a progressive cellular dysfunction that happens, and renal function starts decreasing, resulting ending in a end-stage renal disease. So this is the natural history of diabetic nephropathy in patients. So as you can see, the red line is the GFR and the blue line is the albuminuria. So as the stage progresses, the GFR starts falling. And there are different criteria for each of that. I'm not going to go into detail of that now, and albuminuria starts increasing. So by the time a patient reaches end-stage renal disease, his GFR will almost be less than 30, in fact, less than 15 actually. That is when a patient is, needs to be going for a renal replacement. So it goes through various stages where different things happen. And as it reaches an overt nephropathy stage, wherein the eGFR decreases sort of rapidly, at that time there will be a macroalbuminuria. That is, urine will be more than the albumin in urine will be more than 300 mg per 24 hours. And there will be an increased blood pressure. They will also have associated retinopathy and all of that. Sometimes they can have normal sized kidneys also. So ultrasound is not a very great indicator to look for. In a lot of patients do that. They want to do an ultrasound to see is my kidney fine, but that is not a very great indicator at all. Ultrasound will be normal almost till the end. By the time an ultrasound detects a chronic kidney disease, it's too late. So doing another test, which is looking for microalbuminuria, is more sensitive, and that is a much better screening test. So, like I said, microalbuminuria is the earliest evidence of diabetic nephropathy. Even before there is actually damage, visible damage, microalbuminuria can be detected. So most of the patients will be asymptomatic. So that's why we need to test. Okay. So some of the symptoms that can happen is fatigue, anorexia, nocturia, and all that. So, like I said, there are three things. One is albuminuria and abnormal sediments in the urine and elevated creatinine. So, make sure that you screen for microalbuminuria annually. You can do it in 2, 3 ways. One is you can do a random microalbumin creatinine ratio, which is MAC ratio, we call it. So, that has to be less than 300. So, or you can do a 24-hour, you take a 24-hour urine sample and you can look for the albumin, microalbumin in that. So you can do it in any of these methods. So make sure that every patient with type 2 diabetes, you're screening since the time of diagnosis once a year. In the patient with type 1 diabetes, you can start at 5 years after diagnosis because the patient is much younger. Normally, they wouldn't already, have any kidney damage. So you can start screening them 5 years from diagnosis. How do we manage? So make sure that the sugars are very well controlled. HbA1c has to be less than 7%. Another thing to keep in mind is the medications, because as the creatinine starts increasing, you can't give all the medications of diabetes. So you'll have to adjust the dose, like metformin or even the sulfonylureas and all. You'll have to check what is the upper threshold for that particular medicine and change accordingly. Also, you'll make sure that the BP is well controlled. BP target is less than 130/80. So you can use ACE inhibitors or ARBs. These are recommended because they have been seen to slow down the renal damage as well. The other thing is exercise, stopping smoking cessation, advise the patient on a DASH diet, which is a low sodium, low potassium, low protein diet, as well as treat the any underlying urinary tract infections that is there, because that can precipitate a increased damage of the kidney vasculature. Also, as the patient starts going towards an end stage renal disease, you need to start preparing the patient for renal replacement as well and dialysis. So going ahead to diabetic retinopathy. So this is another microvascular complication that can happen. So this again is one of the leading cause for blindness in those between 20 to 24 years. So this is again another thing that you have to be careful about, you have to be mindful about. So this again happens because of hyperglycemia mediated damage within the, basically diabetes can affect any blood vessel anywhere in the body. So everywhere, wherever there are end organs, you can have end organ damage that happens. So that is why retinal microvasculature also can be affected in a similar fashion, the same pathophysiology that happens in any of the other microvasculature in other organs. So this again passes through different stages. So you can have mild DR and then goes to moderate, severe, then it becomes proliferative and resulting in vision loss. There are various findings in this, like exudates will be there, cotton wool spots will be there, there will be microaneurysms, creation of new blood vessels, so revascularization happens, hemorrhage can happen. So all of these are some of the findings. So what are the risk factors for diabetic retinopathy? So nephropathy is one of the risk factors. In the sense, it's not that nephropathy causes the retinopathy, but usually they both can, happen together. So if a patient is having nephropathy, then you have to make sure that you look for retinopathy and vice versa. If you detect a patient with retinopathy, there's a high chance that the patient may have nephropathy. So they are both very interlinked. They can happen together. So if one is there, make sure that you look or screen for the other. The other thing is genetic factors. If the patient can be more genetically prone to developing a retinopathy, and in pregnancy retinopathy progresses. So with patients with type 1 diabetes, you have to be very careful, especially when they get pregnant. And if the patient has, the diabetes has started at a much earlier age, then definitely the greater risk of developing retinopathy is there. If the patient also has associated hypertension, high lipids, high blood pressure, obesity, all of that can also result in. These are all some of the risk factors. So it's not just retinopathy, but there are other eye problems also that are more common among diabetic patients, like, of course, one is the diabetic retinopathy and the macular edema, which is also part of the retinopathy that happens. You can also have glaucoma. Diabetes does not cause glaucoma, but there has been seen that the cases of glaucoma, incidence of glaucoma is seen more among patients with diabetes, as well as cataract, especially the snowflake cataract can happen. You can have retinal vascular occlusion resulting in retinal detachment. There can be vitreal hemorrhage that can happen. There can be ocular muscle paralysis that happens, resulting in weakening of the eye muscles. And there can be optic neuropathy also. So all of these things can happen. They are more common among patients who have diabetes. So how do we manage? See, management is this almost the same. So you have to screen, look for retinal damage yearly, do a retinal examination yearly, have a tight control of sugars, blood pressures, and cholesterol. Lifestyle modification is very, very, very important for any of these complications of diabetes. Normally, if the diabetic retinopathy is mild or moderate, then there's no need for any treatment. You just need to regularly follow up and control the sugars. But if the patient is having severe or very severe, if the patient is in that stage, or if he's in a proliferative or macular edema stage, then you can refer to an ophthalmologist. They will need to do a procedure, maybe a laser photocoagulation or something like that. You can also do injections, like intravitreal injections can be done of steroids or anti-VGF. So all of that will need to be done. So you can just refer a patient to the ophthalmologist.